Okay, let's get started. Good morning, everyone, and thank you for attending our Grand Rounds lecture. I am pleased to introduce to you our speaker, Dr. Pillai. Dr. Pillai is Assistant Professor of Medicine in the Division of Clinical Cardiac Electrophysiology at the Pauley Heart Center, VCU Health. Dr. Pillai has the distinction of being the youngest graduate of the University System of Georgia, obtaining his Bachelor's of Science in Biochemistry at the age of 17. He completed medical school at the Medical College of Georgia at the age of 21. He served in leadership roles throughout his medical training, including being chief medical resident and chief cardiology fellow. He was elected to Alpha Omega Alpha Medical Honor Society in 2016. He also received awards for Outstanding Fellows and Outstanding Clinical Investigator at VCU. Dr. Pillay joined the faculty at the Pauley Heart Center as an early stage clinical investigator, where 50% of his time is dedicated towards clinical research. His work focuses on exploring the impact of conduction system pacing in patients with heart failure syndrome, leveraging novel applications including machine learning, cardiac MRI, and cardiopulmonary exercise testing. We are grateful for Dr. Pillay's expertise on this topic and look forward to learning from him. At the end of the lecture, we will leave time for questions. Please submit questions via the chat function on Zoom as they arise during the talk. We are pleased to offer both CME and MOC credit for our Grand Rounds conference series. To claim credit for today's section, take the code shown in the beginning and end of this presentation to 804-625-4041. For questions or to log into your Cloud CME account, visit vcu.cloud-cme.com or contact Shannon Wiston. I will now turn it over to Dr. Pillay.
So thank you very much for that very kind introduction. It's humbling speaking at this conference, especially with the caliber of folks that we usually have here. So I wanted to share with you all some of our work in left bundle branch area pacing. And really our focus has been towards novel insights. How do we predict response and optimize function in left bundle branch area pacing utilizing some of these modalities, cardiac imaging, machine learning, and exercise physiology. So our objectives today are to first start out with a background, understanding the basic hemodynamics of cardiac pacing, the detrimental effects of long-term RV pacing, and to review some of the limitations of the conventional therapy of cardiac resynchronization therapy. We'll look at some novel ECG approaches that we've pioneered here at UVA, VCU and UVA in collaboration, some application of cardiac imaging and left bundle branch area pacing, and if we have time at the end, I'd really like to dive into some exercise physiology and left bundle pacing. And as means of disclosures, I do serve as a consultant for Medtronic. So to start to understand the limitations of RV pacing, we have to go back to 1925. This is a monogram from Carl Wiggers, published in the American Journal of Cardiology, where he recorded in animals the aortic pulse pressure, the aortic pressure, and the LV pressure during native LV apex and LV base pacing. And the take-home message here is that the site of pacing can acutely compromise electromechanical function of the heart. If we then look at regional high volume curves in healthy volunteers, asymptomatic left bundle branch block, and then patients who then develop symptomatic heart failure on top of left bundle branch block, we see the significant dyssynchrony that is induced within various wall segments in the left ventricle. And if we look at echocardiographic analysis of LV dyssynchrony during intrinsic rhythm and RV apical pacing, immediately after the onset of pacing, we see that speckle tracking strain analysis shows us that in intrinsic rhythm, there's significant synchrony and isorhythmic contraction of all LV wall segments. However, in RV apical pacing, we see significant dyssynchrony, and there's actually a significant delay of up to 130 milliseconds between time to peak strain of the anterior septum, which is that yellow arrow, and the posterolateral segment, which is the purple arrow. The story of pacing-induced cardiomyopathy can perhaps be thought to have its first act in 2002 with the David trial. To determine the efficacy of dual-chamber pacing compared with backup ventricular pacing in patients with standard indications for ICD implantation, this study enrolled patients that did not have typical indications for antibradycardia pacing. 506 patients with an EF of less than 40% were randomized to either backup pacing with VVI at 40 beats a minute or forced pacing atrial and ventricularly at 70 beats a minute. And we see that the DDD group, or the forced pacing group, had significantly higher percentages of ventricular pacing and a significantly higher rate of heart failure hospitalization at 22.6% versus 13.3%, and a trend towards worsened mortality. Contrary to the pre-specified hypothesis in this trial, treatment with dual chamber pacing was associated with an increased mortality and increased heart failure hospitalizations at 1 year compared with VVI pacing. So this was the first signal that unnecessary pacing may be detrimental in patients who had low EF and no indication for ventricular pacing. That's all well and good, but those patients did not have a pacing indication. In the MOST trial, Michael Sweeney and other investigators, including Dr. Ellenbogen, sought to ascertain whether DDDR pacing, which preserved atrioventricular synchrony, may reduce heart failure in AFib compared with VVIR pacing in sinus node dysfunction. And in this subgroup analysis, they also tried to isolate the effects of pacing from other forms of electromechanical dyssynchrony-induced cardiomyopathy. So they only included patients who had a baseline QRS of less than 120 milliseconds. And we see a significantly higher rate of heart failure hospitalization with a hazard ratio of 2.99 and a fairly broad confidence interval. But interestingly, the risk of atrial fibrillation also increased linearly with the percentage of ventricular pacing from 0% to 85%, implying significant dyssynchrony, caused some degree of elevated left atrial pressure, backflow into the left atrium, and perhaps reverse remodeling or adverse remodeling. So now we know desynchronization of the ventricle imposed by ventricular pacing increases the risk of heart failure hospitalization and AFib in patients with a normal QRS, regardless of the preservation of AV synchrony. These results were since further expanded upon. In this illustrative study from the Cleveland Clinic in 2016, patients with complete heart block and an EF of greater than 50% who developed pacing-induced cardiomyopathy were analyzed and underwent cardiac resynchronization therapy. Of 823 patients, a whopping 12.3% developed pacing-induced cardiomyopathy over a mean follow-up of 4.3 plus or minus 3.9 years. In this study, the post-pacing EF was 33.7% versus 57.6% pre-procedure or without pacing. And RV pacing percentage arose as a continuously associated variable with a hazard ratio of 1.01 per 1% RV pacing burden increase. It should be noted that in this study, the CRT response rate was actually fairly high at 84%. But again, we now understand that pacing-induced cardiomyopathy is not uncommon in patients who receive conventional RVA pacemakers for complete heart block with preserved EF. Not only does pacing-induced cardiomyopathy occur frequently, but it also occurs relatively rapidly. This is from investigators at Emory, including Faisal Merchant. Using a market scan database, they identified about 7,000 patients with complete AV block and about 14,000 patients without AV block. The primary endpoint in this study was new heart failure assessed over an acute 0 to 6 month time frame, and then chronic 6 months to 4 years post-pacemaker implantation. And what they found is that the risk of pacing-induced cardiomyopathy is highest during the first 6 months post-implant in patients who have complete heart block. In the chronic phase, a risk for pacing-induced cardiomyopathy still remains, but it appears to be slightly attenuated when you compare it to the first 6 months. So now we know that there is an increased incidence of heart failure hospitalization, which is most notable 6 months after a pacemaker is implanted, and greater than 10% of individuals with complete heart block will present with a clinical diagnosis of heart failure 6 months post-implantation, at least in this analysis. We know that there are acute and long-term effects of RV apical pacing, and we also know that the effects of RV apical pacing on the myocardium and the body are multifactorial. There are congruent effects of electromechanical dyssynchrony, abnormal perfusion and oxygen demand, abnormal contractile function, which then increases end diastolic pressure and left atrial pressure, causing maladaptive cardiac remodeling and neurohormonal signaling and sympathetic activation. So with all of these things together, you have to hypothesize that pacing-induced cardiomyopathy may manifest by means that are slightly more subtle than just a drop in ejection fraction. So I want to emphasize to you that pacing-induced cardiomyopathy is a spectrum. It encompasses more than just a strict EF reduction cutoff criteria. Like I said before, at 3 to 4 years, about 10 to 20% of patients may develop some drop in EF to less than 50%. But what percentage of these patients present with increased heart failure symptoms or hospitalizations or AFib or increased biomarkers? If you look at the incidence of pacing-induced cardiomyopathy by definition, stratified by these three definitions that are shown on the screen in the PACES study, this was about 118 patients only with pacemakers that were followed pre and post pacemaker implantation, but the prevalence of pacing-induced cardiomyopathy ranged from 5.9 to 39%, depending on the definition, at a mean follow-up of about 3.5 years. So based off of the results of these studies that I presented, decades and time and research were put into AV synchrony, AV delays, dual chamber programming modes in pacemakers before the advent of cardiac resynchronization therapy and conduction system pacing. But I want to tell you that there are some potential pitfalls with these algorithms. With these algorithms, the AV intervals are not restricted in single chamber pacing modes. So you can have disruption of that atrioventricular synchrony or AV timing that leads to AV decoupling, or conversely, VA coupling, where the V is paced and the A then it conducts back up to the atrium. So this can be severely symptomatic for the patients. It can cause some degree of adverse remodeling and also can be potentially proarrhythmic due to long-short sequences that occur in these algorithms. How do these algorithms perform in the real world? Well, here's data from at least one meta-analysis that shows, despite uniform evidence that ventricular pacing reduction modalities reduce ventricular pacing, they do achieve their intended goal. They do not improve clinical outcomes, and they're not superior to standard programming in reducing the incidence of persistent AFib, all-cause mortality, all-cause hospitalization in patients with a preserved LV systolic function. So if RV pacing is not the complete answer, what is? Well, then enter the world of biventricular pacing. And before we get to that, I just want to highlight to you that RV apical pacing and left bundle branch block induced cardiomyopathy all fall on the spectrum of desynchrony associated cardiomyopathy, who Dr. Huizar and Dr. Tan at the VA have really pioneered a lot of work in this area. This falls into a class of cardiomyopathies that seem to have some similarities. Markers of desynchrony dose are about the same, the RV pacing percentage of 20%, the PVC burden of 20%, QRS width of pacing or of PVCs, left bundle branch block, QRS duration. All of these things seem to come together. And at least for pacing-induced cardiomyopathy and left bundle branch block, biventricular pacing arose as a treatment modality of choice. These are images from the landmark Block HF trial, which I want all of our fellows to know, where 691 patients with AV block and an EF of 50% or less were randomized to CRTP or D with conventional IV pacing and a coronary sinus lead. They were then randomly assigned to either have standard RV pacing, so RV lead on only, or biventricular pacing, both RV and LV leads on. The primary outcome, time to death from any cause, urgent care visit for heart failure that required IV therapy, or a 15% more increase in LV end systolic volume index. Here, the hazard ratio for BIV pacing versus RV apical pacing group was 0.74. And while no one will argue that CRT is the historical treatment of choice for these desynchrony-induced cardiomyopathies, I do want to highlight for you that a significant driver of outcomes in this trial was reverse LV remodeling or reducing LV end systolic volume index. So that should potentially be one of the goals that we are pursuing with all of these modalities for resynchronization. What's the problem with biventricular pacing? Well, here's a figure from the 2012 EHRA-HRS expert consensus statement on CRT and heart failure. And it shows that regardless of the endpoint that you use, heart outcome measures, remodeling measures, soft clinical function measures, or clinical composites, the range of non-response rates can vary from 17% up to as high as 40 to 50%. Some of you may look at this data or these studies and suggest that maybe goal-directed medical therapy was less effective during this era. This document's from 2012. But even if we look at more contemporary trials, like the SMART MSP trial that was presented 2 years ago at Heart Rhythm Society, we find a non-response rate with biventricular pacing of 25.9%. So as such, there's an entire science that has arisen around CRT non-response. And for the fellows, I just want to emphasize that many things can contribute to suboptimal BIV pacing response. In general, you can characterize them with the three Ps: patient selection, suboptimal lead position, and non-optimal device programming. Now, let's focus in on suboptimal lead position. We know that LV pacing site is one of the factors that is correlated with CRT response. Here, we see the electromechanical underpinnings of that correlation. In a study of about 33 patients, they measured DPDT max, assessed at implant with a pressure wire sitting in the LV cavity, and the largest percentage rise from baseline to DDD pacing was used to determine the optimal CS lead position, independent of any ECG criteria that we conventionally use. And in these patients where you did that, LV end systolic volume decreased from 186 to 157, and 56% of patients exhibited reverse remodeling. There was also a significant relationship between percentage rise in DPDT and reverse remodeling in both non-ischemic and ischemic cardiomyopathies. So it is important to achieve significant hemodynamic benefit with the placement of these leads. It's not enough just to place them anywhere and move on. What is the optimal site then for LV pacing? Many have suggested that endocardial pacing is the answer to this. And some of you may know that various techniques have been trialed in the past, including retrograde aortic leads or transeptal lead implantation into the LV myocardium. The most recent incarnation is this WISE CRT device where a small piezoelectric sensitive pacing electrode is implanted into the LV myocardium, and it's then stimulated via wireless ultrasonic energy transmission. Seems, like science fiction, I think. But initial results from SOLVE CRT were published in January several years ago, and patients included 48% CRT with non-response and 42% with unsuccessful CS lead implantation. And a significant number of these patients had a modest but not insignificant rise in EF and evidence of LV reverse remodeling. But that is a bulky device. There's lots of things that can potentially go wrong. It's a two-step procedure. Can we achieve this endocardial pacing by a more simple means from the right side of the heart, as opposed to exposing the patient to potential thrombosis risk? So enter LV septal pacing, left bundle branch pacing. And this actually goes back pretty far. This is from Fritz Prinsen's group in the Netherlands in 2009. They were the first group to show benefits of LV septal pacing. After AV nodal ablation in dogs, they were randomized to receive 16 weeks of pacing at the RV apex, RV septum, LV apex, or LV septum, and RV pacing resulted in significant greater electrical desynchronization compared with LV septal pacing, where there was improved mechanical synchrony and coordination when they used MRI tagging to look at synchrony. So I've shown you some pretty pictures there, but does that translate hemodynamically? Well, the initial evidence said yes, 10 patients with sinus node dysfunction with invasive DPDT max measurements. LV septal pacing resulted in shorter cure restorations, retention of the baseline DPDT, and stable lead sensing and pacing thresholds. And while there were ongoing efforts to translate this clinically, the first group, of course, was a group in China. And of course, Dr. Ellenbogen was somehow involved, as he always is. But this is a case report of a 72-year-old female with dilated cardiomyopathy and EF of 32% and a cure restoration of 180 milliseconds, who had failed CS leads, failed his lead implant, went to the distal left bundle branch, and was able to result in significantly improved synchrony and EF response. So how do we do left bundle branch pacing? Well, these are fluoroscopic images, and in our mind's eye, we have, well, we see the atrial lead and we see the left bundle lead being inserted here. In our mind's eye, we can superimpose the conduction system onto this fluoroscopic view and understand where we think the conduction system might be. In purple, that's the left bundle branch going into the LV. And if we look at during the procedure itself, injecting contrast in a left anterior oblique projection where the LV is highlighted here in round or a circle and the RV is more of a D shape, we see that the lead goes across the septum into the LV septal region and almost touches the LV endocardial border. We have robust retrospective data now looking at left bundle branch pacing since February of 2019, where it really started to take the US by storm, showing that left bundle branch pacing achieves narrower QRS durations than bi-V pacing and has significantly greater improvements in heart failure, EF improvement, and potentially death in retrospective results. So the most recent HRS guidelines for cardiac physiologic pacing allow for a class 2A level of evidence C guidance for the use of either His bundle pacing or left bundle branch block, left bundle branch area pacing in patients who have conventional CRT implantation criteria. And prospective data is coming. This is the left versus left study funded by Picori. It's the largest left bundle study to date, powered for survival, driven by VCU and Baylor University with Dr. Ellenbogen and Dr. Chelu. And we're very excited to see the results of this trial with several subgroup analyses ongoing. But what I want to talk to you about today with the time that I have remaining is how do we take left bundle branch area pacing from the era of Carl Wiggers and bring it into this era of AI and beyond. So let's talk about some novel ECG approaches. A lot of this research work, for me at least, started during my fellowship. I was interested during cardiology fellowship in EKG criteria that were achieved with left bundle branch area pacing. In particular, if you look on the left side here, we see all the various QRS morphologies that I was seeing in these patients as I reviewed our database. Some of them had a QR in V1, some of them had a right bundle branch block looking morphology, some of them looked more like an incomplete left bundle branch block, some of them looked like a left anterior fascicular block. So, does the QRS morphology impact outcomes? And interestingly, when we looked at QRS morphology at the time of implant compared to the day after implant in the Sankey diagram, we see significant change. A significant percentage of patients went from one morphology to another. And it made me think, well, either we're not achieving what we mean to achieve, or QRS morphology is not enough. And we had similar performance over all of these groups. And, the clinical intuition, at least, whenever we think of syndromes like Brugada syndrome, when we're trying to elicit a diagnosis, we've put leads on the septum, higher and lower than we typically would, and look for the development of an R wave or that J wave. And here we see if you place V1 in interspace higher and V5 in interspace lower than we typically would, then you can either lose or gain an R wave just by where you put the leads on. So how do the leads vary between the time of implant and the procedure and the time that they get to CVPCU? There's a lot of variability there. And yet, in the most recent consensus statement from the European guidelines, these are all of the criteria that are used for achieving left bundle branch area pacing. It's really complicated. I'm not going to go through all of them, but you see that there's so much emphasis placed on the QRS complex. And we see some of these transition changes showing those same morphologies that I showed you earlier in that work from my fellowship. So we do all these measurements in the lab, the stim to QRS intervals, the left ventricular activation times, the V1 to V6 interpeak intervals. We're really just nerding out on these QRS complexes. Is there a way to simplify that complexity? That is my question. And this is where work that myself and Dr. Ken Bilchik at UVA have been able to make some progress with functional principal component decomposition, where we weight each representative EKG lead complex before and after implant compared to a gold standard QRS and a gold negative standard QRS. So we have these two basis functions, 1 and 2, compare each lead to that. Mina Chung's group at the Cleveland Clinic has actually used a variation of this using PCA or two-dimensional PCA, and they retrospectively analyzed 946 CRT patients, and PCA was actually able to stratify left bundle branch block groups into lower and higher risk mortality for reaching a component endpoint. And a second group had a lower risk of composite endpoint with a hazard ratio of 0.44 and a much greater EF improvement with biventricular pacing in patients who had left bundle branch block, even when their QRS was over 150 milliseconds. So this was an improvement of the conventional criteria that are used to guide biventricular pacing indications in heart failure. So our ultimate goal was to be able to integrate functional principal component decomposition analysis of these pre and post-procedural ECGs, and then combine that with other characteristics like imaging and clinical outcomes to help guide our implant technique. So we were able to do this in a very small cohort. This is kind of our investigational data looking at 25 patients. 40% of these were female. They had a median baseline QRS of 156 milliseconds and a median baseline EF of 33%. 40% of our patients had an absolute EF improvement of at least 15%. And looking at those particular patients, we were able to characterize that the ECG leads with the best functional principal component decomposition parameters to identify that 15% EF increase. We really wanted to go for the super responders, as it were lead 3 post-pacing and lead AVF pre-pacing with an area under the curve of 0.88. So very impressive results with a very small cohort. Our hope is that this will hold true or potentially be improved with greater numbers, and this signal is being used to justify an ARC level grant in collaboration with UVA with Ken Bilchik. So let's talk a little bit now about cardiac imaging in left bundle branch area pacing. We do a lot of cardiac MRI here, and I know that all of our fellows and our cardiac MRI readers spend time looking at these hearts. And you understand that each unique heart shows different combinations of mechanical contraction, strain, scar. And the thought has to arise, is there a way to personalize the procedural approach to each of our patients? So what can we gain or glean from cardiac MRI? Well, we have cine imaging, we have scar imaging, we have parametric mapping, and we have strain imaging. Some of this has been looked at already. Groups in India have actually looked at the impact of late gadolinium enhancement on the success rate of left bundle branch area pacing. One of these initial results was retrospective observational and single center, where they looked at about 25 patients. Starting EF was similar between groups. They stratified based off of presence of septal scar or absence of septal scar. The QRS duration was higher in patients who had septal scar. And in those patients who had late gadolinium enhancement, there was a significantly higher percentage of patients who failed achieving conventional characteristics for left bundle branch area pacing. So if you have scar in the septum, it's unlikely to be successful. Similar to conventional coronary sinus lead implantation. If you try to pace scar, it's unlikely to be effective. In these 35 patients from another group, successful deployment was achieved in 30 out of 35 patients. However, if the septal LG was less extensive, you were more likely to have successful criteria. If the scar percentage was over 40%, you were less likely to be successful. Our question then moved on from scar assessment to how do we look at synchrony? And what we decided to utilize was a dense sequence. This is a modality of cardiac MRI strain imaging, where strain is encoded into the phase of the cardiac MRI signal. And then we utilize that imaging to generate 3D maps of LV function and synchrony. So this study, in collaboration again with Ken Bilchik at UVA, was a 2-center cross-sectional single visit study with a goal accrual of about 40 patients. We performed cardiac MRI scans on patients with conduction system pacemakers 6 weeks after implant, with standard imaging and with dense strain imaging. Our primary outcome measure was EF by cardiac MRI, and our secondary outcome was RV function, strain, and uniformity. Our inclusion criteria are listed here. Basically, what we did to try to compare apples to apples was we forced paced from the atrium and then allowed normal conduction. So they see that nice normal QRS there. And then we paced both in the atrium and the ventricle. And in these patients, interestingly, what we found is that in left bundle branch area pacing, there was a significant reduction in septal synchrony, which is a little bit counterintuitive. You're pacing the septum, but what appears to be happening is you're activating the conduction system. You actually are bringing in the lateral wall of the myocardium slightly faster than the septum itself. And as a result, you seem to have a fairly good approximation of conventional or intrinsic QRS synchrony, despite these regional variations that are induced with left bundle branch area pacing. So not exactly what we were expecting to see, but interesting data nonetheless. When we look at median LV and RVEF in these patients, they were similar with left bundle pacing on and off, but there were significant differences in synchrony, with that mean septal dysynchrony being induced and the LV free wall being brought in a little bit faster. So interestingly, we find that despite these changes, left bundle branch area pacing appears to be helpful. When we look at predictors of LV function and global strain, we wanted to compare these strain measurements to conventional criteria that were used. So we see these criteria in the bottom right, these QRS or EKG-based criteria. And interestingly, that V1 to V6 interpeak interval, which is what I'm showing you on the bottom right, is associated with selective left bundle capture. And that was the best predictor of a greater EF with left bundle branch area pacing. So again, validating some of these EKG-based criteria that we came up with that have not yet been validated with non-invasive imaging. A shorter pace QRS duration here predicted greater global synchrony and global synchrony as well. When we look at predictors of response in a larger cohort of patients, so this isn't the full cohort, we have about 40 patients to date, we see that in patients who have intact AV conduction and left bundle pacing, in all of these patients, LV end systolic volume index with pacing moderately correlated with pace QRS duration. RV end systolic volume index was not significantly correlated, but the changes between LV and RV end systolic volume indices did appear to be highly correlated. So this kind of comes into some of the relationships between RV and LV pacing, depending on where that lead is implanted within the myocardium. It matters where the lead goes. And we see that patients who have a completely positive QRS in lead V6 had much more favorable reductions in LV end systolic volume index, much more favorable reverse remodeling with left bundle branch area pacing compared to patients who had other types of QRS morphologies. So LV reverse remodeling may be dependent on implanting the lead in the proximal left bundle, where you are more likely to have a completely positive R wave in V6. And it shows that that initial work that I started to look at during fellowship kind of holds true. Even though the performance of the pacemaker is relatively similar across all these QRS morphologies, they're not all the same. And you can't rely purely on the EKG V1 criteria, which is what a lot of the guidelines look at nowadays. So if we look at left bundle pacing and superimpose in our mind's eye that conduction system, again, it's very easy here to try to understand where the conduction system is. But when we're implanting the device itself in the EP lab, we have no idea where the conduction system is. A lot of it is done by inference and by pacing characteristics. An interventional cardiologist is able to visualize these stenoses before intervening on it. But how do we visualize the conduction system before pacing it? Well, one answer may be CT scan. This is a recent manuscript in JAMA Cardiology showing that with non-invasive visualization in cardiac CT, you see differences in the Hounsfield unit characteristics in the conduction system of the AV node. And in here in purple, you actually can visualize the AV node with a different level of attenuation compared to the rest of the myocardium and actually localize it non-invasively. If we look at another modality, this is actually in ex vivo explanted hearts looking at a novel modality of CT that actually exposes the heart to almost 18 gray of radiation and takes 18 hours to perform. However, we can image the conduction system in high detail. So can we then go back and look at the conduction system in other modalities? This is in conjunction with a company that is led by Shlomo Ben Haim, who actually invented a lot of the mapping systems that are used in electrophysiology to date. And we showed that with cardiac CT, you can visualize the lead. And in contrast enhanced CTs, they actually are able to pick up on subtle differences along the septum, which they believe are the left bundle branch. So we've looked at this retrospectively with a cohort of our patients who have CT scans and who then have left bundle branch area leads. And interestingly here, we see an example of where they thought the conduction system is. In green or yellow here, we see where the tip of the lead is expected to be. And we see in this particular patient, the lead is in contact with the septal fascicle of the left bundle branch. And we have the conventional criteria that we expect to see in V1 by the guidelines. And we have all these implant characteristics that support left bundle branch area pacing or left bundle branch area capture. Good isoelectric intervals, equivalent intervals between recording a potential and actually stimulating the ECG, et cetera. Now, if we look at an example of the opposite, where the lead is not in apposition with where the conduction system is expected to be, here, about 8 millimeters away, we see the opposite. The QRS does not look the way we expect it to be, and we do not have any of those implant characteristics that are conventionally appropriate or looked for to achieve left bundle branch area pacing. So this is very interesting, and our eventual goal is to be able to incorporate some of these synchrony-based measurements and EKG criteria and imaging guidance into the procedure itself, overlaying where we can expect the left bundle branch to be and be able to guide lead implantation in real time in the EP lab, similar to what you would expect to see in an interventional cardiology procedure or in an ablation, for example. Last but not least, I want to talk a little bit about some of my interest in exercise physiology. A lot of this interest started in the EP lab itself. I was implanting a pacemaker in a patient who had a right bundle branch block, and I had a beautiful result with my left bundle branch lead. And I was curious, with all of these different left bundle branch area pacers, we induce what looks like a right bundle branch block. So there has to be some degree of delay in RV activation. So I thought I would measure it. I placed the atrial lead down on the RV free wall and just looked at the differences between stimulating from the very tip of the lead and stimulating from the ring. And if I overlay where I think the conduction system is here, we see the left bundle branch area and the right bundle branch area. Could this ring electrode, which is not conventionally used, potentially stimulate the right side of the septum? And I saw that RV free wall activation was advanced by up to 30 milliseconds in these patients when I stimulated from both the tip and the ring. So is it possible that we result in greater or improved interventricular synchrony? This is important because, at least in this Mayo Clinic registry of exercise testing from 1993 to 2010, patients who have no known cardiovascular disease, defined as an absence of coronary disease, structural heart disease, heart failure, or cerebrovascular events, were analyzed. They identified about 22,000 patients, only 220 had right bundle branch block, but these patients were followed over a long period of time, up to 23 years. And right bundle branch block was independently predictive of all-cause mortality with a hazard ratio of 1.5 and cardiovascular-related mortality after adjusting for age, sex, diabetes, hypertension, and obesity. Now, what about RV function and exercise? If we look at results from Andrew Legurk's lab in Australia and a lot of other high-functioning exercise labs, we see that RV coronary oxygen demand during exercise increases disproportionately compared to the left ventricle. Myocardial oxygen consumption and coronary venous oxygen tension in the RV and LV during treadmill testing is increased. And it suggests that the RV work increases disproportionately compared to the left ventricle during exercise. This was conventionally done in a cohort of athletes versus non-athlete humans, but we also know that patients who have left bundle branch block or significant heart failure have been shown to have some degree of preserved RV synchrony, and that RV function can be predictive of better outcomes in heart failure patients. So is RV timing potentially a modifiable feature in left bundle branch area pacing? This is our heuristic framework where we're looking at stimulating the left bundle branch from the lead tip itself only, or increasing power output of the pacing device and capturing both the lead tip and the lead ring, where potentially we would stimulate not only the left bundle branch, but also the right bundle, or at least the right side of the septum. So what is the best way to analyze this? It's not at rest. Some people have looked at how this functions at rest, and it seems to be equivalent. But there is significantly higher response in patients who have pulmonary hypertension or right bundle branch block. So you have to stress the system in some way, and you have to be able to image the right ventricle adequately. Well, we know that cardiac MRI is a modality where we have excellent fidelity for right ventricular volumetric analysis and functional analysis. The problem is when you put a patient in an MRI machine, you have MRI noise reversion, you have magnet mode induction, you go to a dyssynchronous pacing mode, which is why we have to go through all this rigmarole before every patient with a pacer goes into an MRI machine. But if you establish telemetry with the patient's device, you can inhibit all of those things. And as part of our MRI collaborative study with UVA, I started to look at what this actually looks like. And we see that in patients in the cardiac MRI room, there's not a lot of artifact. During the scan, there is artifact, but the electrograms are still noticeable and identifiable. And even in the setting of atrial fibrillation, where generally we tend to see very low signals, the device is able to see this very effectively. So this is where I've taken this with my initial pilot trial called the Focused Right trial. This is our clinicaltrials.gov ID, where we're taking patients with pacemaker settings off, pacemaker settings to left bundle branch pacing only, and pacemaker settings to left bundle branch plus this anodal capture or stimulating the right side of the septum. And we're exercising them at low intensity exercise and imaging them with a cardiac MRI. And we've completed a few patients to date, and I'm very excited to present those study results, hopefully at another grand rounds in about 6 months to a year. So hopefully I've given you an idea of how we can at least start to take left bundle branch area pacing from this era of hemodynamic only data into the modern era. I appreciate all of your attention today. I want to thank all of my mentors in the electrophysiology division and in the cardiology division at large, our collaborators, and dedicate this talk in memory to the person who inspired me for this topic, Santosh Padala, who we all remember fondly and love. So thank you all very much. I'll leave this on the code for CME credit and there and take any questions that you might have.
Thank you so much, Dr. Pillai, for the fantastic talk. We have a question from Dr. Lenaski. Is septal depolarization intramyocardial body from the lead, whereas lateral activation is via conduction system?
That's exactly right. And that's why we see the desynchronous results in the cardiac MRI. That's how we hypothesize that the function is allowed to occur. And I think potentially by being a little bit more creative in the way that these leads simulate the septum, we may be able to improve myocardial demands and synchrony in the septum compared to the lateral wall, or at least we hope we will be able to.
I have a question. So I think it's very interesting when you mentioned that when patient have cardiac MRI and patient have septal scar, so it's less likely uh, have to have benefit in that patient, but not many patient not all the patient that have cardiac MRI do you, in when you see patient in the clinic and patient how do you decide that this patient is going to have the benefit from the left bundle area pacing rather than the conventional CRT?
That's an interesting question, and it's something that I've wanted to look at. There is not a lot of data in the modern era looking at scar distribution in typical Strauss criteria left bundle branch blocks and left bundle branch block like interventricular conduction delays. So whenever you look at that EKG of the patient, first of all, when is it most important? It's most important in patients who have heart failure, wide QRSs, and a left bundle branch block. In those particular patients, you want to look at the QRS morphology and see, is it a conventional left bundle branch block or is it a little atypical? When I see an atypical left bundle branch block, I'm a little bit more worried that left bundle branch area pacing will not be successful. And we may need to think about the addition of a coronary sinus lead also. And in those patients, we're more likely to pursue imaging to characterize the myocardium before device implantation.
Thank you so much.
AJ, great talk. Early in your talk, you showed several studies that highlighting certain pacing strategies were associated with an increased risk of atrial fibrillation. What is the mechanism behind that? And is there anything that we should be considering in the patients that have these devices to try to implement so that we prevent the occurrence of atrial fibrillation?
Yeah, it's a great question. I think there are multiple factors that can contribute to the development of AFib with RV pacing at the very least. One of them is just the plain dysynchrony that's induced, the adverse remodeling, elevations in end-diastolic pressure and elevations in left atrial pressure. All of these things can result in dilation of the left atrium and adverse remodeling. But even some recent evidence, Dr. Gertz, myself, Jeffrey Kolominsky recently looked at ventricular dysynchrony in MR patients and atrial fibrillation burdens. And there was a signal that arose in that study that dysynchrony in and of itself could potentially result in worsening atrial fibrillation burdens. So I think whenever we see these patients, especially patients who have heart failure and left bundle branch block, our goal should be to correct that as much as possible. So I think that's where I'll leave it. I'm sure there are more nuanced answers that folks could give you, Dr. Hunling, but what other thoughts do you have?
No, I was just wondering what the mechanisms are, and do we need to be following left atrial size by echo more frequently? Are there any things that we need to address so that we avoid the development of that condition in these patients? Yeah, I don't have a good thought. I wondered, in your review, had you observed anything that folks have come up with in that
No,
regard?
there hasn't been a lot of guidance. I have noticed that, there is data looking at resynchronization therapy in AFib incidence, and it is lower with both conventional biventricular pacing and with left bundle branch area pacing. I think that monitoring needs to be more regular, and we need to look at not only LVEF, but also focus in on markers that are a little bit more subtle. Left atrial size, as you said, left ventricular end systolic volume index or end diastolic diameters, and of course symptoms. So I try to monitor these patients at least every year whenever they come into clinic for me, but I'm still developing my own practice patterns for that.
That might be an opportunity for just a really nice retrospective assessment, to set up a quick research study to look into that. What were
Very,
the forecasters?
very true.
Ajay, this
Great
is Dr.
job.
Can you hear me, Ajay?
Yeah, yeah.
Okay. So I'm going to ask you a very loaded question here. Um, how do you reconcile the science of conduction system pacing, all the things that you've shown us, with leadless endocardial pacing, like that trend?
Yeah, I don't reconcile it very well, and I've spoken to many people about this. So obviously, when you think of leadless endocardial pacing, these are devices that are implanted on either the RV apex or the RV septum, and the degree of atrioventricular synchrony that is achieved by at least some of these devices is questionable at best. We do know that there is evidence that came out of Wake Forest that depending on the site of lead implantation, the development of RV-induced cardiomyopathy or RV pacing-induced cardiomyopathy seems to vary. So if you put this leadless pacemaker in the RV apex, the rates are higher. If you implant it higher on the septum, the rates are lower. But we also know that procedurally, the risks of implanting it on the septum are slightly higher as well due to the torque that's induced on those sheets and the subsequent risk of right atrial damage or perforation. That data in the real world outside of that single center has not really borne out. I recently reviewed a paper out of Geisinger where they looked at the relative rates of pacing-induced cardiomyopathy with leadless pacemaker versus conduction system versus BiV, and the rates were higher for leadless pacemaker across the board.
Yeah.
So I think that eventually my hope is that the field will move towards a convergence of these two paths. It seems like all device companies are barreling down the road of leadless pacing for cosmetic reasons and for the risks of infection, which they perhaps overstate at times. And then also at the same time, barreling down this road of conduction system pacing and physiologic resynchronization. Eventually they have to converge. And there are some interesting thoughts that I've been, or discussions that I've been privy to, but nothing that's really come to light yet. So hopefully more to
Yeah.
come, GK. That's
Thanks,
all I can say.
Does anyone have any more questions? Oh, if no question, we are going to end the grand round today. Thank you so much, Dr. Pillai, for the fantastic talk today.
Thanks so much, everyone. Appreciate your time.
Thanks, AJ.
Take care.